So hi, I'm Navdeep Tangri, and Elaine, you can come into the frame.
Hi,
this is Elaine. We're the team from the University of Manitoba at Seven Oaks Hospital, and we're going to be, along with Kathy Woods, who's the other member of our team, the patient member. The three of us are going to be presenting to you about our project focused on delivering risk-based care for patients in family practice and in nephrology practice eventually. So I'm going to just remove the distraction of the camera and focus strictly on the slides. Okay? So here we go. So 600,000 Canadians have stage 3 to CKD or higher. That means their kidney function is less than 60%. I suspect that of these 600,000, probably less than 50,000 are actually managed by kidney doctors. So the vast majority, like 500,000 plus, are actually managed in primary care or family practice. As all of you know, some of these patients progress quickly with their kidneys function rapidly declining and perhaps needing dialysis or transplant. But in others, in fact a good majority, kidney function can remain stable for years. So if we treat everyone the same, and we give everyone the same advice and the same counseling and the same recommendations about kidney disease, we're really doing a disservice to both groups. Because what we're doing to low-risk individuals is creating unnecessary anxiety, a burden of a chronic disease label, and possibly psychological distress which may lead to missing work and a diminished quality of life. In high-risk individuals, if we don't tell them that they have kidney disease and don't tell them what they can do about it, we really create a very limited opportunity to learn about kidney disease and to delay and prevent progression. These patients, when they're not recognized early, tend to be less likely to choose home dialysis or a permanent dialysis access and have a higher risk of hospitalization and early death on dialysis. So if we treat everyone the same, we make low-risk patients worry too much, and we make high-risk patients not worry enough. So we're really not delivering the right care to both groups. And it's even bad from a health system perspective. If we treat everyone the same and send everyone to a kidney doctor, we'll create increased wait times for urgent cases, and we'll create more rapid disease progression because of these increased wait times. And if everybody goes to see the kidney doctor, and then the kidney doctor, there's no way they can have enough time to prepare all the patients appropriately. They don't have enough time to pick out the right ones and prepare them for dialysis or kidney transplant. So what do? I think to kind of change this equation, we need risk prediction. A risk prediction is the science of predicting like a probability of an event happening for an individual patient. So for taking a set of data about the patient, whether it's their age, their diabetes status, or whether they smoke or not, and let's say predicting the risk of having a heart attack in the next 10 years. In our case, we take a small number of variables that are routinely collected, and we try to predict the risk of kidney failure and requiring dialysis in the next 5 years. We think this has several benefits. We think it leads to early and appropriate nephrology care. So early care for those who are at high risk and appropriately conservative care for those who are at low risk. We actually really strongly believe that patients and doctors want to know their prognosis. Sometimes, like in cases of kidney disease, the prognosis can be changed. If you look after your blood pressure, if you look after your blood sugar, you can actually slow the decline of kidney disease. So in this case, it's really important. But studies have shown that even when prognosis can't be changed, patients and doctors still value knowing prognostic information because it helps them plan their life. It gives them certainty, it empowers them. There are also other benefits for health systems, such as clinical trial enrollment and dialysis resource management, but those are not really the focus of our work. So here's the equation we developed. It's called the kidney failure risk equation, or the KFRE. It accurately predicts the risk of dialysis in patients with CKD stages 3 through 5, so anybody with a GFR less than 60, for up to 5 years. And we've shown that it's accurate across multiple countries and in subpopulations. By subpopulations, we mean patients who are old or young, those who are diabetic or non-diabetic, or whether they're male or female. The equation is simple, it's highly accurate, and can easily be integrated into clinical practice. In fact, the websites that I'm going to show you that incorporate the equation and the apps are accessed more than 30,000 times a month. So 1,000 times a day, a doctor looking after a patient with kidney disease in the world uses this equation to inform their clinical practice. So that's quite powerful. They're really the most valid equations used for predicting kidney failure worldwide. This is what they include. So your urine protein, which is from a urine sample, your sex, your age, and your GFR, which comes from creatinine. So you take these 4 variables and we can figure out the projected risk of kidney failure. All of this work came from a paper we published in 2011, which is shown here, and subsequently this is what the equation kind of looks like, and this is what it looks like on an iPad. I'm going to try and show you a visual demonstration now. So, okay, so here we go. So you can see, I can all screen my screen, right? Yes? Yes. So here we have a 70-year-old male in Canada who would have a GFR of 40 and a urine albumin creatinine ratio of 200 milligram per millimole. So that's a lot of protein in the urine. So the equation would show that this patient has stage 3 kidney disease and their risk of dialysis at 2 years is 5% and at 5 years is 15%. This patient would be intermediate to high risk because their risk is more than 15% over 5 years. So this is how, this is one way that the equations are used in clinical practice as we speak. Okay. Now I want to show you how we can clearly show the patient this, but I want to show you some of the more interactive things we're planning to do in this trial. So we work with a group of colleagues at Mayo Clinic, and what we want to develop is help patients help develop tools that help patients understand their risk and then show them what they can do about it. So I want to show you a sample from a different decision aid, one developed for heart disease, and I want you to try and envision how we would do this in kidney disease. So this is called the statin choice decision aid. So let's get started. The way this is meant to do is your doctor should open this when you're sitting in the clinic. So the doctor goes to your current risk and he says, okay, you're 70 years old, you're a male, you're white, let's say, you smoke, you have diabetes, and you have high blood pressure. And let's say your blood pressure is 140, your good cholesterol is 1.2, and your total cholesterol is 5. Then it shows you that of 100 people like you who don't take a medication for heart problems over the next 10 years, 49 will have a heart attack and 51 will have a no heart attack. So if you don't take this medication, you essentially have a 50-50 chance of having a heart attack in the next 10 years. Then it allows you to choose an intervention. So let's say we choose to be on a high-dose statin like Lipitor, which many of you may be familiar with. So then it shows you that if you take Lipitor, over the next 10 years, 100 people like you, only 29 will now have a heart attack, 51 will have no heart attack, and 20 will be saved from a heart attack by taking this medication. So your odds go from 50-50 to 70-30. So the blue balls are the ones that are now saved, and only the bad yellow ball frowns, there's only 30 of them instead of 51. Then it shows you what are the issues. So it leaves these markers here. Well, there's the issue of cost, so the statins cost this much. You have to take 1 pill a day, and they also reduce your stroke risk. Well, what are the side effects? Well, side effects can include nausea, diarrhea, constipation. 5 out of 100 patients will develop muscle aches, and 2 out of 100 will have some liver damage, and 1 in 20,000 will have kidney damage. And then you go to your notes or document, and basically what you say is that I've used this decision aid, and after considering the pros and cons, we've decided to do what? So we've decided to start the medication. So this is the kind of science, decision science, that we want to bring to patients with kidney disease, because right now it simply just doesn't exist. So maybe I'll pause here and I'll get some feedback from Kathy on what you thought of this decision aid, and maybe from some of the other patient partners that are on the phone.
Kathy here. I was just wondering, in terms of the risk equation, is there many, with any risk, with any statistics, there's always a plus or minus, or that are, you know what I mean? Like, what is that rate for this risk equation?
Yeah. So the risk equation for our kidney equation, it's sort of so for the kidney equation, it's accurate about, we think it's accurate between 85 to 90% of the time.
Okay.
And like the equation I showed you for heart disease, which is the most commonly used one for heart disease in the world, is actually only accurate about 70 to 75% of the time. So what we find, we've also done some studies showing that comparing the risk equation to just a doctor's guess, and the equations almost always do better than a doctor or a nurse's guess at who's going to progress.
So will all the doctors now have access to this information?
Yeah, what we're hoping, so we'll go through, Elena and I will go through how we're going to allow doctors access. And in fact, we're going to go, us or one of the research partners from the study, are going to go to each clinic that's randomized to the intervention, and we're going to show doctors how to use it. Like, we're going to do a full presentation just like this, and we're going to integrate it into their computers so that they can pull it up anytime. And we're going to ask them to use it every time they see a patient with kidney disease.
Wow.
Yeah.
I just think it'll be really helpful because, like, when I went to my primary care physician, it wasn't good. Like, he had no information on what, other than telling me I had nephrotic syndrome, and then the stay and the wait to be able to see a specialist, right? And although it wasn't that long for me, at the time, it seemed like forever, right? When you have when you've been told this diagnosis, and and I think I was one of the, like, I didn't want to be looking up a lot of information because I wasn't sure, what would be accurate information, what wouldn't be accurate information. So one question about the equation. Does it have a way of, like, pinpointing what type of kidney disease you have, or is that...
what we try to do, Kathy, is in the one the one I'm showing right now. This is the one that comes from our kidneyfailuerisk.com website. We ask the doctor to go through the stages first, and then go through the causes. And we show here that diabetes, hypertension, immune, or inherited. So yours would be immune. Nephrotic syndrome is usually immune, or other. So we would want, when the doctor is going through this with the patient, we'd want them to kind of circle the one for the patient. This handout becomes personalized because you see it has your results at the bottom, and it has that patient, that hypothetical patient that we did. It has their results. So we really do want the whole output to be personalized, and so we want the doctor to kind of walk through the stages, the causes, the difference between kidney disease and kidney failure, how the calculation is done, and what the person's results are. Those are the 5 steps we want covered in the visit.
Okay.
Yeah.
Good.
Other questions from people on the phone? Okay. We will continue. So our big research question is, does providing patients and doctors information about the risk of kidney failure lead to improvements in quality of care, health literacy, and trust in the care that they're receiving? And we're going to show you how we're going to give the information and how we're going to measure these outcomes. So skip that. What we're doing is a national cluster randomized trial. So what it means is instead of randomizing patients where one patient would get the information and one patient wouldn't, what we're going to do is randomize clinics. So in one clinic, doctors would give all patients with kidney disease the information, and in another clinic, they would just continue as they're doing now. So because we want to show that giving this information actually improves outcomes. And the moment we show that, we'll obviously disseminate everything out to all the clinics. But it's important to do these trials to actually show that the time and resources we invest in doing this stuff really makes a difference, to really prove it to funders. So the clinics we're using are part of this network called the Canadian Primary Care Sentinel Surveillance Network. This is an odd acronym, but I'll refer to it again. It's called CPSEN. So CPSEN is a network of 800 doctors and nurse practitioners. They provide care to more than 1.5 million Canadians. There's 134 clinics that are part of CPSEN across the country. And in our trial, 67 clinics will get all this information, and 67 will just watch to see what they're doing. All the clinics collect all the data we need for quality, and they automatically report it to an electronic database. So we don't have to get them to collect new information, per se, to look at our quality indicators. This is not a good picture, but it kind of shows that there's a CPSEN clinic in every province except for Saskatchewan. We want to have 67 clinics in each arm, as I said, 134. We want to have good representation in each province. And what we want to do is we want to provide this individualized information to patients, and for the doctors, we want to show them some pathways as here's what you should do for patients with low risk, here's what you should do for patients with high risk, and so on. In the control clinics, our trials, our risk tools are already out there. Some of the doctors may be already using them, but what we're going to do is provide no extra information. So they're free to do whatever they want to do. If there's a really proactive doctor from a control clinic which wants to use the tools, they can go ahead, but we won't be actively counseling them and putting it into their computer and so on and so forth. All clinics will receive their provincial guidelines. So even the clinics where we don't go and do a visit, they'll receive the provincial guidelines on how to provide good kidney care. So what we're going to do is, over 12 months, we're going to visit these 67 clinics and do and provide this entire kind of toolkit to doctors to share with patients. And then in the next 24 months after that, we're going to see if the care they provide changes, if they are providing better kidney care. The way we do it is the CPSEN, all the CPSEN clinics have this DPT, which is a data presentation tool. That's how the doctors are able to see all the patients in their clinic. They're able to see how many have diabetes, how many have kidney disease, how many have arthritis. And we want to integrate our equation into their tool so they can see which one of their patients are low, medium, and high risk, and we can provide links to all our nice graphics that we've created. We also want to do audit and feedback, so we want to show each practice what their current quality of care is. So how many of their patients are getting testing for albuminuria? How many of the patients with high albuminuria are on an ACE inhibitor? And what is the current risk profile of their clinic? And what proportion of patients at high risk are currently being referred? How we deliver these tools is by doing something called medical detailing or academic detailing. We've done this before once in kidney clinics, and it really works quite well. What we do is we have an in-person visit from a key opinion leader, which means in every province we find an investigator who's a well-known kidney doctor in the province, and we use that person to go and present to the family physicians on CKD, on the accuracy of the risk equation, on showing them how the patient and physician decision aids can be used, and try to encourage a patient-provider discussion about the risk. We also try to identify a local champion, which means that at the end of the specialist visit, we try to identify one family doctor in each clinic who would be the one who would motivate the rest of the troops to keep the momentum for risk-based care. This is the website and video that I showed you. So we try to get them to go through the stages, the causes, that show them that kidney disease is different from kidney failure, that this is the equation, and this is what it looks like. Then once we've done that, we want to show, did providing this information, did it increase the percentage of patients who were tested for albuminuria? Did it increase the patients who got an ACE or ARB? Did it improve blood pressure control or blood sugar control? These are the two things we'll be targeting in our education intervention. And finally, this is obviously a long shot because it's only 3 years of follow-up, but it'd be nice if we even saw a change in kidney function between the two groups at 3 years. From a system perspective, we want to see whether appropriate referrals are being made for high-risk patients, and we want to measure the cost of kidney disease care. We think risk-based care will reduce costs because low-risk patients won't get unnecessary testing. We'll do all of this by getting data from the EMRs and looking at provincial guidelines and linkages with administrative data. In a small subset of patients, a smaller subset, we also want to gather correct data directly from patients. And there, we're looking at the trust in their care, but more importantly, we're looking at their health literacy. So what we want to do is we want to give patients a questionnaire about, once they've had a visit, we want to give them a questionnaire about what they know about kidney disease. And this is a questionnaire that was developed in, I think, at Vanderbilt University. It's quite good. Ask just basic questions like, what do the kidneys do? What's a good blood pressure for someone with kidney disease? You know, what is protein? What's GFR? And what we want to see is, if we implement this risk-based pathway, does the knowledge about kidney disease improve? Because we actually believe that knowledge is empowering. We think that patients who have more knowledge of kidney disease will tend to make better decisions. So we want to measure that in a smaller subset of clinics. We also want to measure, from the family doctor's perspective, their satisfaction with the risk prediction tool and the clinical decision aids. We're hoping to work with Kathy and the rest of our patient partners in refining the protocol as we work with Mayo Clinic as well to design that kind of decision aid, which shows the risk with, what if you take better control of your blood pressure? What if you take better control of your diabetes? And then with interpretation of the study findings, and eventually we think patients can really help spread the word of our study and move the results to practice. To date, we've developed the decision aids that we showed you so far, and we've started a connection with Mayo to start working on the new decision aids that'll show the risk in two separate scenarios. We've also shown that there's 460,000 patients in SIPSN clinics, that have a measured GFR, and we've shown that there's 65,000 patients that have CKD stage 3 that would be impacted by our intervention just in SIPSN clinics alone. So we're going to have a big impact because 32,000 of these patients will get this intervention and 32,000 won't. So we really have a very large trial. We've identified the SIPSN data presentation tool as the way we're going to implement this. We haven't started the actual coding because we're still in the stages of ethics review, and we'll be, once we finish that, we get our contract signed, then we can begin work on the actual coding, and we'll be working on that hopefully in the latter part of this year. We think that if we're able to successfully integrate this risk equation and these pathways in primary care, it'll lead to reduced anxiety and improved knowledge or health literacy for patients, and it'll lead to more appropriate referral for the healthcare system. We think ultimately that'll result in a reduction in wait times for specialist care, which is a big, big issue in Canadian healthcare, and will result in improved access to specialist care for high-risk patients. So if we can get low-risk patients to be safely managed by their family doctor, the total number of referrals should go down, and therefore high-risk patients who actually really need to be seen will be seen sooner. Thank you. That's our vision. I'm going to try to figure out how to. That's good. I'll leave it there. Okay.
Now,
yes.
question: do you have any Simpson clinic northern locations?
Sorry, any Simpson clinic where? Sorry.
Do you have any of the Simpson clinics in northern locations?
You know, I haven't dug into it that much. I've tried to work. I wanted to really refine the aids in the 2 clinics in Manitoba and 2 in Alberta first before we explore. But I will. That's a good question, and I'll ask the Simpson people if any of them are rural or remote. The ones in Manitoba are in the city.
Yeah, that's what I was just wondering because, you know, the ones that come into the clinics in the city are going to be in the latter stages. That's how they're able to get to be able to come out of their communities. Yeah. You know, and I'm just wondering how we'd have an impact in rural locations to be able to make sure that we're having an impact.
Yeah, I think your point is really also valid for not only just northern, but also clinics in really poor populations, like even very poor urban people or lower educated people. Well, I think we'll have to make sure that the tools we employ are accessible to everyone, that they're not just either for people who are already at a very high, you know, operating at a very high education level.
Yeah, well, I think that's something that the patients can be helpful with in terms of the aids is making sure that it's in layman's language and that, you know, from a are able to understand things, you know, without any medical knowledge in terms of things, and I think that would be really helpful. Do you think it's still helpful for you to hear from any of the other patient council members about their first experience and that type of thing? Because we were thinking
absolutely. Absolutely. I know we've always talked about when the first time they ever were told that they had kidney disease, how was the diagnosis delivered and what was going through their mind?
Yes, and also what would have been helpful to know at that first or second meeting that they had with their family physician and that, because I think that would be really helpful, and we can think about you know, it might be, I'm not sure what you're presenting, how much of your project you're presenting, but to be able to get that, we can talk about maybe, Heather, getting that message across at the patient council meeting if people would like to share that information with Nav.
Yeah. I'm trying to see if I can see the questions as well. Chat. There we go. Okay. There's a question from Selena saying, is there a plan to integrate the risk prediction tool into existing care pathways? Yeah, so I think, Selena, that's a good point. Both Ontario and Alberta have well-defined care pathways. So our goal is to actually disseminate the local care pathway and provide the risk prediction tool that's kind of an overlap, but not contradicting in any way, but it's complementary to the care pathway.
Thanks, Nav.
I just have a silly question. Why are there no Simpson clinics in Saskatchewan?
I have no idea. So I just only learned about Simpson. Maybe there is one now since that last visit, but I wonder why. There's you know, it's that kind of a funny idea of a local champion. I think in the end, to launch something, you need somebody who's really, really willing. So maybe they never found the right local champion. No?
How many are there in Manitoba?
2.
2, and they're both local.
Yeah, they're both in Winnipeg. Yeah, 2 large clinics. Yeah.
2 large. So there's nothing in the Paw or Brandon or.
I don't think so. I don't think so.
Wow.
Yeah.
We need to ask some pretty tough questions.
Yeah.
Kathy, it's Heather.
Yeah.
I have a question. If you don't mind me asking you, what was your initial wait time before you were able to see a nephrologist?
I was diagnosed with my disease on October 25th, and I didn't see a nephrologist until January the 12th. But during that time, I had an abundance of tests and scans, full body scans, all sorts of blood tests. The type of disease that they thought I had is normally caused secondary to something, secondary to lupus or cancer or whatever. And they first had to rule out that I had no cancer present in my body. As it turns out, my disease was idiopathic, which means it, that it just was there, and it was present in both kidneys. And I didn't find out until February 12th, and through a kidney biopsy. Don't ever have one, but
Okay.
it indicated that I had membranous neuropathy, and before that I didn't know. And it was really a rough time because I had gone to an internist, and my family physician kept calling me and telling me, your test for AIDS was negative. We're going to move on to the next one, and like doing all this testing. And I went to an internist a week after my diagnosis, a week after finding out, and when your kidneys aren't functioning, your blood pressure goes up, and your blood sugar and all of these things go up. And so this doctor told me that it was their job to keep me alive till they found out what was wrong with me. So by the time I got to see Dr. Commenda, by the time I got to see Dr. Commenda, I was a basket case. I mean, as thin as I am, I had lost another 10 pounds. My doctor, because he knew I had too much protein in my urine, put me on a protein diet that I was limited to 20 milligrams of protein a day, and 20 milligrams of protein a day does not sustain your body. And I was just literally falling apart because I didn't know what I had. And then as soon as I got to see Dr. Commenda, he took me off the diet. He wanted me to eat and drink normally and do all these things and stuff. So it was a world of difference for me. And I don't know, I still don't know in terms of pre where I would have slotted in, because I had 20 times as much protein in my urine as you're supposed to have, and my ACR level was in the hundreds. So like I said, I don't know if I would have slotted into a high risk or into a lower risk. I have no idea where I would fit in. So like I'm a technologist, so I understand statistics and numbers and stuff, but I'm just glad that at least they're going to be able to equip the family physicians with the information that will be helpful to patients, to help them to understand their disease as opposed to not knowing anything.
Great, thank you. So you were about 2.5 months or so.
2.5 months, and it took after a couple of months, it took after 6 weeks, when I still hadn't heard, my doctor and my internist refaxed and called the information again to there was 2 places I could have gone. I could have gone to Health Science, or I could have gone to Seven Oaks. By the grace of God, I got to go to Seven Oaks because I just wanted the first available. It didn't matter to me. I would have went to the guy in the corner if I would have thought he would have been able to give me the information I needed on that. So.
Thank you. And Nav, if I could just ask you, is there a sort of an average wait time that people would wait to see a nephrologist?
So the beautiful, there's an excellent question, and almost like a softball setup question, because in Manitoba, the wait time to see a nephrologist used to be 10 months, and we actually adopted the risk equation as a way to triage new referrals, and in 2012, we took that down from 10 months to 2 months.
Wow.
Using this exact same, exact same pick care pathways that we're talking about. So right now, the wait time to see a new patient in Manitoba is less than 2 months.
Great. And it wasn't a planted question, let me tell you.
Yeah.
Now, see, I was diagnosed in 2011.
Yeah. So this is why you would have, like, I mean, if you were referred, I mean, I think you were seen in a pretty timely fashion because somebody picked up. Yeah. Somebody picked up that this was important, but I mean, if you were referred today, you would be seen with, guaranteed you'd be seen within 4 weeks.
Yeah, it's good to know.
Yeah.
Now, I can see another question on the screen there. Do you have it in front of you?
Yes, so I'm just going to read it out. Selena's question is, can you explain how patients will be given the education? Will it be done by family doctors, and how will you ensure that they actually provide the materials to the patient? So my point is, I think we actually can't force the doctors to provide the educational materials to the patient. All we can do is hope that the material is compelling enough that they see the value in discussing it with the patient this way. I think that's the beauty of this type of trial, is that it mimics real life. If we did a trial where we randomized each patient, one patient to receive the materials and another one to didn't, and then we showed that the patients who received the materials did better, it would almost be artificial. You know, it wouldn't be broadly generalizable. If we can just say that simply giving these materials, putting them in the hands of doctors, if the materials are really great, I think they will share them with the patient. I firmly believe that, to doing in the pragmatism of the trial.